it's great to have an opportunity to speak to you guys about paediatric rheumatic diseases, because it's something that's probably not covered in great detail within the curriculum. There's so much to fit into your placements and things like that. So it's great to have a bit of time to speak to you all about this. And you can see from the first slide here that one of the reasons we wanted to talk today in particular is that we're coming up to the 18th of March, which is World Young Rheumatic Disease Day. And this is a national awareness campaign that we've actually been involved in setting up quite a lot alongside the Paediatric Rheumatology European Society. So it's all about promoting and getting the word out there that children and young people get rheumatic diseases as well as adults. So for today, we want to talk about why it's important to recognise rheumatic diseases in children and young people. We'll talk a bit about pattern recognition, so the different ways that patients that we see can present and how you can go about making a diagnosis. I'll tell you a bit more about Word Day and why we think it's important to raise awareness, and why our patients think it's really important that we raise awareness of paediatric rheumatic diseases. And then we'll have a small break for some questions, and then Gavin will take over and talk through some cases. So I don't know how many of you have seen a patient with a paediatric rheumatic disease. I wonder if we put ourselves on gallery view for a second, if you could put your thumbs up if you've ever seen a kid with some sort of paediatric rheumatic disease, or raise your hand if you can't do thumbs up. Oh no, because I'm doing the presentation, I can't actually see the full gallery. Let me look through. I'm just going to flick through. So lots of people haven't got their camera on. So far I've seen 4. Okay, so this is something you really need to know about. If there's only 4 people in the room who have heard about paediatric diseases, they're actually far more common than you might think. And grouped together, if you take them all together, they've probably got about the same instance of type 1 diabetes, and I'm sure you've all seen someone with diabetes. So in your time, you will see someone with a paediatric rheumatic disease. So the reasons why they're important to be picked up. So if you don't pick them up, they can lead to permanent damage. So the types of things that we see in patients who've had a delay in their diagnosis are joint contractures. So on the left-hand side here, you can see that this person is trying to straighten out their leg and trying to get it down onto the bed, but they can't. The leg's in a sort of fixed flexion. Similar with this elbow, this person can't straighten out her elbow. You can also see that this leg looks quite skinny as compared to the other one, so there's muscle wasting as well. And it doesn't take much to show that there's really sort of significant joint deformities here. This person can't straighten out her fingers. This poor child had such bad involvement of the TMJ, the joint in the jaw, that she had to have a trachea because it was compromising her airway. Juvenile idiopathic arthritis is the main sort of type of arthritis, and we'll come on to it a bit later, but it's got this association with uveitis, inflammation in the eye. And if that's not picked up and dealt with quickly and promptly, you can end up with cataracts. And we have got children who have had to have surgery for cataracts, you know, even at the age of about 5. The other thing that you can see with arthritis is leg length discrepancies. So you can see here that this boy is trying to put both his feet on at the same time, and this one is shorter. Similarly here, you can see that there's a little crease on that side and not on that side, suggesting some asymmetry. And here, where we've asked them to put their feet on the bed at the same place, you can see that one of the legs is a bit shorter than the other. So that can create a problem with a limp. It can create problems with sort of imbalance of the legs and pains. So all these things are really important to try and prevent. In kids with more systemic diseases, so not arthritis, but more systemic, widespread inflammatory diseases, some of the complications that we've seen are things like kids needing dialysis and conditions like lupus, if they've got kidney failure, needing transplants, having strokes, problems with really bad circulation to the fingers leading to autoamputation. And this is a child with a type of scleroderma, which can cause atrophy of the face and sort of quite severe involvement on one side of the face. So all these things are treated much better if they're picked up quicker. So in terms of the way that patients present to us, you could sort of broadly group them into 2 different camps. There's the camp that come limping, and there's the camp that come with a more widespread inflammatory disorder. So limping is actually fairly common. If you spend any time in a paediatric A&E department, you will see a child that limps, because actually there have been studies showing that every 58th child that comes to A&E will be limping. And it's an atraumatic limp. So it's not that they've hurt themselves, it's that they've developed a limp spontaneously for some other reason. Not all limping children have got arthritis that's going to go on. Not all of them have got juvenile idiopathic arthritis, this type of arthritis that we see. There are lots and lots of other causes, and it's really important to exclude the other causes before you make a diagnosis of GIA. So they could have it because of a sepsis, they could have a bone infection, they could have a joint infection, they could have a malignancy, something like a leukemia, or they could have a range of other inflammatory diseases. The systemic conditions, you'll have heard of some of them probably from adult rheumatology and adult practice, things like lupus. So the childhood version of that, we call it juvenile systemic lupus erythematosus. Juvenile dermatomyositis, so a condition affecting the skin and the muscles with inflammation. Scleroderma, you've probably heard of. You might have heard of systemic sclerosis, which we don't see very much in kids, but we see more primarily skin involvement. Behçet's disease, where you get joint involvement, but you also get genital ulcers and inflammation of the eyes. There are autoinflammatory disorders, so involving the innate immune system, so the immune system that usually fights particularly viruses going wrong. A condition called chronic recurrent multifocal osteomyelitis, so inflammation of bones in potentially in multiple areas that's not due to infection. So that broadly, they come in these two different areas. In terms of the things that are important to sort of pick out from the history, there are. So the first thing that you always want to exclude is something like an infected joint. So an infected joint could look a bit like this. So hot, swollen. The patient would usually have a temperature, they'd usually have raised inflammatory markers. It's usually very painful, and they usually really don't want to move that joint. It's really important to treat this quickly, because untreated it can cause significant damage to the bones and the joints, and can lead to sepsis. So that's in an acute presentation, you definitely want to make sure that they haven't got a sepsis. In terms of the other things that you need to think about, so you want to make sure that they've not got a malignancy. So we know that children that are limping might be limping because they might have very active bone marrow as part of something like ALL. These patients would tend to have night sweats, bruising, they might be pale, you might see abnormalities in their full blood count. There is a condition called reactive arthritis. So arthritis that's happened following something like an upper respiratory tract infection or a gastroenteritis. And often these children have recovered from their sort of primary infection, and then maybe a week or two later, they seem to have problems with their joint, often the hip, and they seem to sort of be limping. And this is something that happens just because the body's reacted to this infection, and for some reason, for a short period of time, it also seems to then react to the joints and cause this reactive arthritis. And this settles down largely with using things like anti-inflammatories like ibuprofen, naproxen. The other thing to think about, particularly in a toddler who might be limping, who might be sitting with their spine really extended, is something called discitis, where you get inflammation in the intervertebral discs. If they've got night pain, if they're waking, that's really a red flag, both for inflammatory disease, but also for malignancy. So that needs to be taken seriously. If somebody's complaining of pain, which is worse on exertion, but relieved by rest, then that's a very sort of mechanical sounding pain. I've left juvenile idiopathic arthritis to last because it's really quite a diagnosis of exclusion. You need to have thought about all of these things first before you make a diagnosis of juvenile idiopathic arthritis. And in terms of the things that children complain who've got an inflammatory arthritis, it tends to be stiffness, which is often worse in the morning, or if they've been immobile for some time, like sitting, watching the telly or in the car. often parents might describe that they look like a little old man in the morning, you know, struggling to get down the stairs. They can complain of pain, but often pain isn't actually the predominant feature. And often there is some loss of function. So there may be, you know, not doing the things that they wanted to do before, but often, especially in the younger children, they try to sort of work around it, and signs like that can be subtle. And you wouldn't make a diagnosis of JIA until they've had their symptoms for at least 6 weeks for most types of arthritis. And the reason for that really is that things like this reactive arthritis, infections and things, by 6 weeks, all those things will have gone away, or should have gone away. So then it's more appropriate to make a diagnosis of JIA. In terms of the inflammatory conditions, so I touched on these briefly, and these pictures show some of the features of these things. So lupus, you've probably heard of before in the context of adult rheumatology, and many of the features are very similar. Often children have more severe disease than adults. They tend to suffer from a lot of fatigue, so overwhelming tiredness really. Mouth ulcers, hair loss, arthritis. They can have a rash like this on their face, which we call a malar rash, where it goes over the cheeks, bridges the nose, down onto the other cheek, but usually spares around the mouth, spares the nasolabial fold. They can have other rashes, shortness of breath, hematological abnormalities. It can involve the kidneys, and they get proteinuria. It can involve the brain. It can involve any organ, really. And it's very different in the way it presents in different patients. So say you might be one patient who might have fatigue, mouth ulcers, hair loss, rash, you know, some fairly subtle and maybe more minor signs, or there could be someone else who develops really bad kidney involvement or brain involvement. So it's very, very variable. Then juvenile dermatomyositis. So juvenile, under the age of 16, skin and muscle inflammation. And in these pictures, you can see some of the skin inflammation that you can get. So these red patches over the joints, and we call these Gottron's patches. You can also see, even with the naked eye here, that this person's got very red nail beds, and that's because of capillary dilatation around the fingers there. You can see around the eyes, it's got a heliotrope rash. Sometimes they can have a malar rash. And they have muscle weakness, which is more usually proximal, so shoulders, the sort of thighs, than it is distal. And if they've got inflammation in their skin for quite some time, they can get calcium deposits in the skin. Although I talked about juvenile idiopathic arthritis in terms of the limping camp, there's this type of juvenile idiopathic arthritis which is systemic, and it's more sort of in keeping with these inflammatory conditions, where somebody is really very unwell with temperatures, arthritis, often hepatosplenomegaly. They might have serositis with pericardial effusions or pleural effusions, and they tend to have this rash here, which we call a salmon pink evanescent rash, which tends to happen more when they have a temperature. So often they have a daily spike of temperature, often at night, going very high and then coming back down below the baseline. So they're more fitting here. Scleroderma. So here's some different types of scleroderma. So this patient here has got a linear scleroderma affecting his leg. You can see that his leg's quite wasted. He's got some leg length discrepancy as well, or you can have more sort of plaque-like changes like this. Behçet's we talked about briefly, again, very rare in children, but mouth ulcers, genital ulcers, arthritis, and eye symptoms because of this uveitis. Sometimes these patients can have mouth ulcers, and they've been going back to see doctors for ages with the sort of recurring mouth ulcers. And then the thing that happens is that they develop a genital ulcer, which is a bit unusual. We don't often see kids with genital ulcers, and that sort of prompts a diagnosis. Autoinflammatory disorders. So with these kids, they get recurrent temperatures and rash, serositis, lymphadenopathy, musculoskeletal involvement. And these vary quite a lot in their severity and when they come on. And I also mentioned briefly this chronic non-bacterial osteomyelitis. So in a patient who has presented to orthopedics and they're treating for osteomyelitis, and they've given tons of antibiotics, and their inflammatory markers still aren't getting any better, and they're still unwell and things don't seem to be improving, then people start thinking about, is this actually an autoimmune type of osteomyelitis? So that's really a whistle-stop tour through these two camps of disorders, and we'll come back to them in the cases to contextualize them a bit better. So in terms of when to refer to pediatric rheumatology, so it's really important that we see these patients quickly. So just to give you a feel for some of the things that would make us want to hear about these patients. So anytime that you suspect one of these inflammatory disorders or problems with muscle weakness, these are important to be picked up soon. If there's a rash that suggests something like a vasculitis, if they've got Raynaud's, so if you go out in the cold particularly, or even sometimes in the freezer aisle in the supermarket, if the fingers were to turn white, and when the circulation starts to come back very red and sort of purple, they can be painful, it can affect the fingers and toes, then these patients, particularly if they're very young and in the context of other things, then it should make you think about a multi-system disease. If there's somebody who's got uveitis, so we know that inflammation of the eyes can go along with GIA, and sometimes ophthalmologists refer us these patients that have never suffered from a limp or anything, but they've got uveitis, and we keep an eye on them to see if they're going to develop joint involvement. Patients with fever of unknown origin, so can't find an infection. Sometimes these kids could have a pediatric rheumatic disease, systemic diseases, multi-system diseases, limp and joint pain that's not resolving, then we want to know about them. Red flags, which would, if you were a GP, say, suggest that you need to contact general pediatric, would be patients with persistent fever, night pain, weight loss, pallor, bruising, think about malignancies, patients who are not weight bearing, who have got a new painful scoliosis or back pain. These patients need to be referred to general pediatrics, and really, if you do that, it improves outcomes. So what is Word Day all about? I mentioned it very briefly at the beginning. So Word Day is World Young Rheumatic Disease Day, and the aim of it is really to spread the word that children and young people get rheumatic diseases as well as adults. And the main aims over the last couple of years, well, since it's been set up, has been to target GPs and other primary healthcare professionals, general pediatricians, and also students like yourselves, who may be the first people to come into contact with these children, to get people to at least think about these conditions and try to reduce diagnostic delays. It's been launched by the Pediatric Rheumatology European Society, which is the main society in Europe for pediatric rheumatology, and also ENCA, which is an organisation which brings together a lot of the charities and patient and parent organisations for children with rheumatic diseases. And since it's been set up, we've got Facebook pages, we've got Twitter, there's a lot of resources out there that have been used to spread awareness of pediatric rheumatic diseases, and we've written some papers for journals to try and improve awareness. And some of I don't know if it was last year or the year before, we got some of our patients involved in Word Day in terms of helping us to create a video which fed into the global awareness campaign. So I'll share that with you just now so that you can hear from them about why it's important to recognise these conditions.
Today is the first ever World Young Rheumatic Disease Day, Word Day. Did you know that kids get rheumatic diseases like
Juvenile Arthritis?
My name's Charlotte. I got diagnosed when I was 3, and it affects my joints and my life, basically. You could be at school and you could be in so much pain, but yet no one understands it, no one can see it, and it's horrible.
Vasculitis. Juvenile Dermatomyositis. Lupus.
These conditions aren't easy to diagnose. The symptoms can include joint pain, joint swelling, rashes, muscle weakness, fever, weight loss, hair loss, and problems with the blood and internal organs.
I'm Bridget, I'm 14, and I have mixed connective tissue. I've been under I was diagnosed when I was around 9 years old. And it took a long time for me to get diagnosed because they thought it was many different things to start with. Even after I got diagnosed, it took a long time for them to find the right medication. I tried many different ones, yeah. Now, because the medication I'm on works and it's good and it's working for me, it means I can start joining with my friends when they do sports, and I like to bake a lot, so that's good. I can do a lot of baking, and I like to hang out with my friends and try and do normal things now.
Alder have a team of doctors, nurses, physiotherapists, occupational therapists, and psychologists who specialise in diagnosing and treating these illnesses.
In partnership with the first and only experimental arthritis treatment centre for children, groundbreaking research is being carried out at Alder into these conditions.
This is an autoimmune disease in which the immune system is overactive. So it attacks healthy tissue. That's suffer from extreme fatigue, joint pain, muscle weakness, nausea, breathing problems, all of which have a huge impact on my day-to-day life. So I've had the opportunity to take part in a lot of research, which is something that I think is really important in bettering the treatment of lupus to hopefully help other young people like myself in the future.
If children are left untreated, life-changing damage to their body can occur.
There is good news too. Most treatment is very successful.
Early diagnosis, good treatment and care can help many children to lead a normal life.
I can now enjoy the sports I really like.
Do I ever feel like an Well, yes, sometimes. For me, I have a condition called arthritis. When I feel like my arthritis is different, I take inspiration from the creativity of others. Well, getting through my injections, I enjoyed singing. So now I'm into my musical theatre, and I've been selected to be in Bugsy Malone.
Help us spread the word that kids get rheumatic diseases too. Today is the first.
Okay, so I hope you enjoyed hearing from our patients. Obviously, we couldn't, bring people in with us today, but that's as close as we could get. And I think it really highlights why it's so important to know about these conditions. Is there anyone who's got any very quick questions for me? I actually need to join another meeting that starts at 7, but I could maybe take one burning question. Otherwise, Gavin will be able to do questions at the end of his bit. Anything? Okay, I'll pass over to Gavin then. Oh, somebody looked like they were talking there. No. Okay, cool. Enjoy the rest of the talk. Thanks for inviting me.
Thanks very much, Dr. Smith. Thank you.
Okay.
Thank you.